All right, so this lecture is going to encompass the antifungal drugs that are used for control of multiple fungal infections. Sometimes we'll refer to these as systemic antifungals because these are administered either orally or IV, and they reach the systemic absorption. This would be in contrast to topical antifungals, which would be for like dermatological type fungal infections, which we'll talk about in another group of lectures. The drugs that are in these classes include amphotericin B, which is the polyene class of compounds, the anti-metabolite 5-fluorocytosine, or sometimes called 5-FC, the echinoderms, which include capsofungin, mycofungin, and anidulafungin. And then the last group, which are the azoles, and those can be further subdivided into the imidazoles, such as ketoconazole, as well as the triazoles, which include itra, vora, and posaconazole. Okay. Learning objectives stated here, pretty straightforward. Relatively simple group of lectures this go around. So these are the targets of the fungal cell. Excuse me. What I like about this particular slide is that you've got a nice diagram of a fungus and basically showing the molecular framework where all these drugs can have their effect. And so glucan synthesis, which makes the cross-linking portion of the better part of the majority of the cell membrane, can be antagonized by the echinocandin family of compounds, such as capsofungin. Polyenes, such as amphotericin B, can inhibit ergosterol synthesis. Azoles also inhibit ergosterol synthesis through a different pathway or different mechanism. And then, of course, anti-metabolic type drugs, such as 5-FC, can inhibit the production of DNA or RNA synthesis. Okay, so the first group of drugs we'll talk about are the polyene class of compounds. We're really, for this lecture, we're really going to focus on amphotericin B. We'll come back to nystatin, which is also a polyene, in another module or in another course, because that's more or less topically administered. So today we'll focus on really amphotericin B. Mechanistically, this drug will bind to ergosterol and basically reduce the integrity or the structural strength of the fungal cell membrane. And when you start messing around with ergosterol, which is a really important component to the cell membrane within these fungi, the membrane can form pores or channels, and then what happens is that you get leakage of the intracellular contents, and that results in an alteration of homeostasis, resulting in fungal cell death. Okay, excuse me. And so a lot of these drugs have some unique chemistry. We're not going to go into a great deal of the chemistry. The different formulations that are described here basically aid in the solubility of these compounds in an aqueous environment. So, such if you're going to give these drugs orally, they have to at least be slightly altered in their chemistry so that they can become somewhat soluble in water. Amphotericin B by itself is essentially insoluble, and so you have to complex it with a salt to make it a little bit more soluble. And so along that same notion, the formulations, amphotericin B can be topically formulated or topically administered, and they can also be orally and systemically absorbed via IV administration. Okay. Excuse me. The metabolism occurs in situ, so it occurs actually at the fungal cell membrane. And what's interesting is that you don't really need to do any type of dose adjustments or pharmacokinetic considerations for patients that have either kidney or liver disease, which is extremely beneficial. Amphotericin's got a really long half-life, of course. The toxicities that are associated with it include a nephrotoxicity, and this can be the result of alterations in electrolytes, and it can also be the result of renal vasospasms. You can also see an infusion-related toxicity when you IV administer this drug, You can get a cytokine release type syndrome from various immune cells. That looks like fever, in some cases respiratory distress, in some cases hypotension. Um, and in order to combat that or to reduce the incidence of this infusion-related toxicity, we can give patients kind of a slow infusion of amphotericin that's kind of been pre-mixed or pre-medicated with APAP, which is Tylenol or acetaminophen, diphenhydramine, which is Benadryl, and hydrocortisone. And so these three drugs are basically there to kind of prevent the pain and the inflammation that's associated with this kind of cytokine release syndrome. And of course, probably the most potent or adverse effect would be an anemia. And that really stems from the mechanism where less erythropoietin is being produced due to amphotericin administration. Okay, so amphotericin B has a lot of clinical indications. It's a relatively broad spectrum type of antifungal, and it's active against a lot of different types of organisms, which are listed here. And you can also use it for the treatment of, moderate to severe mucosal or systemic type of infections that you would see in like post-transplant patients, patients with HIV/AIDS, as well as patients who have been undergoing chemotherapy for tumors. All right. So the next group of drugs are the antimetabolites, and so this is 5-fluorocytosine or 5-FC. And mechanistically, this is going to inhibit the fungal DNA and RNA synthesis, and it's very similar to the mammalian 5-FU or 5-fluorouracil. That's an antimetabolite that has clinical use in cancer biology as well as treating different autoimmune type conditions, which we will talk about soon. So the mechanism there is very similar. This particular drug only blocks fungal DNA. That's why it's in this particular lecture. We see oral administration with renal elimination, and the main toxicity of note is this kind of bone marrow toxicity that results in myelosuppression, and kind of a very, very rare but still important drug-induced hepatitis. 5-FC is indicated for cryptococcal meningitis. It's also and also Candida infections, specifically Candida endocarditis. Sometimes you'll see 5-FC being co-administered with amphotericin B, and that's because these two drugs work synergistically. So again, that's kind of going back to that Goldie-Coleman hypothesis where you've got two different drugs with two different mechanisms of action and more or less non-overlapping toxicities. And this drug is kind of rarely used as a monotherapy. You really see it used in combination type regimens for various infections that are listed here. Okay, so let's take a break here and we will continue with the azoles in the next video.